So I'm going to be talking about urinary symptoms and hormones, which is incredibly common yet neglected. And I am quite embarrassed really because I didn't think about it for many years. As a GP, I just ignored the fact that women had hormones that affected their genitourinary system. So I'm trying to make up for lost time, and I'm very sorry for all those women that I ignored and neglected. And as a woman myself, I've been very prone to urinary tract infections over the years, and most women at some stage of their life will have urinary tract infections. And for many of us, they can cause a lot of pain, a lot of discomfort, really can be very, very troublesome, yet they are often dismissed. Like a lot of things that happen in women, if they're very common, it seems like the medical establishment isn't that bothered because we all experience something. A bit like menopause, really, isn't it? But we shouldn't be ignoring it. We should be thinking about what's going on. Now, as many of you know, our hormones progesterone, estradiol, and testosterone have receptors on cells throughout our bodies, and these hormones are biologically active. I'm very specific when I say estradiol because it's important to know the different types of estrogen. We also have estriol receptors as well, which is a less common estrogen in our genitourinary system. But if we think about these hormones, they are very important and active throughout our whole urinary system. So that includes our kidneys, that includes our ureters, the tubes that go, we've got two tubes that go from our kidneys to our bladder. And then from our bladder is a short tube called the urethra, which we wee out of. But supporting the bladder and the vagina and the rectum is our pelvic floor, which are great strapping muscles that are really important to lift things up, if you like, so our internal organs don't collapse and fall out when we stand up. And our pelvic floor muscles also have estradiol, progesterone, testosterone receptors in them, and also around the rectum and the area around the vagina and the rectum, that skin, the perineum, it's got lots of receptors there as well. So we have receptors there because these hormones are important. When the hormones work, then we shouldn't be having symptoms. Whereas when our hormones fluctuate and reduce, it can cause a myriad of symptoms. And I specifically wanted to talk about urinary tract symptoms with hormonal changes, not menopause or perimenopause, because there are a lot of women that have hormonal changes at other times of their lives. And many people have symptoms, yet no one's joining the dots because they don't have other menopausal symptoms. But let's think about it. When people have a baby, levels of hormones decline very quickly and hormone levels can be low. And many of us postpartum will have urinary symptoms and maybe vaginal symptoms as well. Women who take synthetic contraception, so that could be the Mirena coil, it could be a contraceptive pill, it could be a contraceptive implant. This will often disturb and disrupt our natural hormones working, and certainly contraceptives like the implant or the synthetic contraceptive, oral contraceptive, so-called the pill, will actually block testosterone working as well, so we have less testosterone in our system. So many people taking contraceptives will think they're on hormones, but they're on synthetic hormones, which can block the role of our natural hormones working on our genitourinary system. And then when we become perimenopausal or menopausal, of course our hormones decline. But for many of us, and I say us, but I don't know when my testosterone started to decline, but for many women, testosterone levels start to decline in the late 20s, early 30s. So many women are testosterone deficient before they're estradiol or progesterone deficient. And testosterone is a very important hormone when it comes to our genitourinary system. So there's a group of us trying to change the terminology. Traditionally, it's called genitourinary syndrome of menopause if people are getting genitourinary symptoms. But many people, myself included, have a myriad of urinary symptoms before we even reach menopause. So we're actually ignoring a lot of women, which is completely wrong. And When people, men and women, but especially women, have urinary symptoms, we have to be thinking about hormones. Many of us have been told that we get urinary tract infections because our ureter's short, because we don't wipe our bottoms correctly, we don't wash properly, or we don't drink enough water. And the more I think about it, the more I think that's absolutely degrading to women. I don't know about you, but if I do a poo, I'm not going to get poo all over my vagina and ureter. I'm older and wiser to do that. It's not like changing a baby's nappy where we're really careful. So I think it's very degrading to think that the bugs from our bottoms could enter our vagina and go into our ureter. Maybe for some people, but most of us it's not. So we have our vaginal microbiome. We've got good bugs in our vagina, and they help to protect our system. But these can alter when we have low hormone levels. So when levels of progesterone, estrogen, and testosterone decline, that can have a negative effect actually on our vaginal microbiome and increase our incidence of having urinary tract infections and symptoms. We also know that our hormones, progesterone, estrogen, and testosterone, are very important for our immune function. They keep our immune system really working very well. So when levels of these hormones fluctuate and decline, our immune system doesn't work so well. So something that could have just been mild cystitis could end up with a more severe infection, or even a kidney infection such as pyelonephritis, because our immune systems aren't primed and working the same way without hormones. It's not all about infection. Some people might get urinary symptoms. So there's a lot of people that have symptoms of cystitis, and they're told they don't have an infection. And it's probably right. I mean, it's a whole different conversation whether we should be doing laboratory tests or not on every woman who has urinary symptoms, because certainly as a GP, I've seen lots of women who have had negative urine tests, but they've got every single symptom of an infection. And when we send a urine sample off to the laboratories to be tested, they can't test for every single bug. So some people we do just treat with antibiotics without doing a sample that's sent to the laboratory. But a lot of people get irritation in the area, and that's often because the hormone levels are low. So these hormones help keep our tissues healthy. They help increase the blood supply to the area, and they help build the muscles and the collagen and all the soft tissue around. So you can imagine if people have vaginal dryness and soreness and irritation, then the skin can be very thin and friable, and so also the ureter can become thin, more prone to be damaged. Any bugs that are there are more likely to sort of get into the bladder and have a deep-seated infection, and then they could ascend up the ureters into the kidneys. So lots of our defense mechanisms, if you like, are down if we don't have those hormones to protect us. And then because the muscles can be positively affected with our hormones, people often find that their pelvic floor muscles don't work as well when they've got low progesterone, estrogen, and testosterone. And so this can lead to symptoms of incontinence. So there's stress or urge incontinence. An urge is when you have to just rush to the toilet. As soon as you're thinking about you needing a wee, you've just got to get there straight away. And if you don't, then you might have some dribbling or incontinence. The stress incontinence is when you cough or sneeze and you might get a dribble. And it's so common. In fact, it's so common, it's hardly ever spoken about because people are embarrassed. But you only need to go to a pharmacist and see all the myriad of products that are available to try, that we can put in our pants or have disposable knickers to hold any drips of urine, which is great obviously to have those as an option, but isn't it better if we can try and prevent that and try and keep our pelvic floor muscles strong, keep our bladder working properly, and reduce the incidence of urinary incontinence? And like I say, a lot of times in the past, I used to refer people to urologists. I used to say, oh, there's not much I can do. And I never thought about hormones. So we need to be thinking differently about hormones, because I've said hormones have a really important role. So it makes a lot of sense, doesn't it, that if we replace those missing hormones, then it's likely that our symptoms will improve. And the earlier we can replace them, the less severe symptoms are going to get, hopefully. And this is why we don't have to wait till menopause or even perimenopause. If young people are experiencing symptoms, then we should be thinking about vaginal hormones, especially, for example, if they're taking contraceptives. I know my daughter, Jessica, my oldest daughter, if she doesn't use regular vaginal hormones with her systemic hormones, she can get a lot of cystitis, which can really be very disabling and affect her negatively. So we don't need to wait until we're a certain age or we're a certain level of our hormones before thinking about hormones as a treatment. Now, I've spoken a lot about HRT before, but I want to just talk about vaginal hormones. Now, these are hormones that we put in our vagina, and they can help with vaginal symptoms, and I've done a YouTube talking about vaginal symptoms before. But urinary symptoms can really improve, because if you think our bladder is next to our ureter, which is really close to our bladder and our pelvic floor. So anything that we put into our vagina can seep out gradually and affect and improve the tissues all around, including our rectum actually, and the tissue, the perineum between. So I've already said we have hormone receptors throughout that area, and currently we only have vaginal hormones containing estradiol and testosterone. We don't have progesterone as a pessary as yet. So there are two different types of estrogen. There's estradiol and estriol, and they are both available as vaginal hormonal preparations, and they're available in different concentrations, and it depends on the country as well what you can get. So they can be used as a vaginal pessary. We've got a vaginal tablet over here called Vagifem, or there's another alternative called Vagirux over here in the UK, and it can be bought over the counter for some women, not every woman, in the form of Gina or Gina. I'm not quite sure how it's pronounced. And then we've got vaginal preparations such as creams or gel, or there's a little silicone ring which is a slow release that lasts for around 90 days, which is inserted in the vagina and can stay there, or it can be taken in and out like a tampon, and then that seeps the estradiol through the tissues into the surrounding genitourinary system. So the other choice is something called Prosterone. In the UK it's also called Intrarosa, and this is really important. Contains a hormone called DHEA, which is a precursor to both testosterone and estradiol. So when it enters the vagina, it gets broken down, if you like, to testosterone and estradiol. So it will stimulate the testosterone receptors as well. And certainly in my clinical practice, I usually use it first line, because what's the point of half treating someone? We know there's a lot of androgen or testosterone receptors all around the urinary tract. So why only give estradiol? It doesn't really make sense. And there's really good data, especially for urinary symptoms, how it can really reduce the frequency of urinary infections especially. And we have to not underestimate urinary tract infections. They are a very common form of sepsis, and we all know how crucially important it is to recognise sepsis. And sepsis kills a lot of people, not just in the UK, but globally. And about 30%, or around a third of all sepsis, is due to urosepsis. So that means the infection has originated in the urinary tract, and a lot of that is related to women rather than men. And so, of course, the older a woman is, the lower her hormones are going to be. And we already know that having vaginal hormones will reduce the incidence of urinary tract infections. Now, I wanted to show you a graph that I printed off earlier for you. So this is looking at estriol, actually, the other type of vaginal hormone, but it doesn't actually matter. This is a graph showing the infection-free percentage of people on two treatments, on placebo or estradiol, and over months, so over a length of time. So I'm going to hold it up here. I hope you can see it. So you'll see the top one. there was 100% of people treatment free, because these are people, sorry, urinary tract infection free. So these are people that had an infection. So immediately after their infection, they were either given estradiol or placebo. So initially, none of them had infection, great. But quite quickly, the placebo group were not infection free. They had infections. So you can see this line was going down and down and down. But look at this here. There were far less infections in people that were given vaginal estrogen. Now you'd think this is a great study. Everyone who's a urologist should know this. Everyone should pin this up and go, this is why we give vaginal hormones. And you might think maybe this is a new study. Maybe this is something that's just come out. Maybe it won't surprise you to know that this study came out in the 1980s. When I was at medical school, this came out. Yet first-line treatment as a prophylactic for urinary tract infections is often not vaginal hormones. Vanishingly few women are still prescribed vaginal hormones, and it's just scandalous when urinary tract infections are so common. Now, there's another graph I wanted to show you here, which is Rachel Rubin's work. Rachel Rubin is a great advocate. She's a great friend and colleague in the US as well, and her work is just fantastic. So she's looking at the prevalence, so the frequency, if you like, of urinary tract infections. And this is in women who have diabetes or don't have diabetes. And we know that women with diabetes, the same as men with diabetes, are more prone to infections. She also looked at women, whether they had symptoms of vaginal vulvoatrophy, so symptoms of dryness, soreness, irritation or not. And then she gave them Prosterone. So it wasn't just her giving Prosterone, it was others as well. But she looked to see, had they had treatment with Prosterone as well or nothing. So what she showed was that people who had no vaginal symptoms were less likely to have a UTI. So this is the prevalence of UTI, and this is the age actually along here. So older women, of course, are more prone to it. So if the frequency increased with age, which is what you'd expect. So if they had vaginal dryness, soreness, then their risk of an infection increased. But look how much it reduced if they were given Prosterone. And if they didn't have any vaginal symptoms, then they still had an increased incidence of a urinary tract infection. But again, look, the line goes down here, you can see. And this is the people on Prosterone. So whether they've got vaginal dryness, soreness, irritation or not, either way, they're less likely to have a urinary tract infection. But if we can treat the vaginal symptoms as well, then they're even less likely. So the difference between the top and the bottom is very impressive. And this is what we need to do to reduce the incidence of urinary tract infections and reduce the incidence of urosepsis and death, because it's avoidable, especially in older women. Now, vaginal hormones can be used with or without HRT, and we really need to be thinking about the role of testosterone to help with our immune function, but also to help reduce the incidence of urinary tract infections and vaginal dryness and discomfort, because a lot of women I see who only have vaginal estrogen don't get a full effect. In the UK, it is available through the MHRA, but a lot of regions don't have it on their formulary, and a lot of women are refused it, which I think is really awful. I know that I wouldn't be able to get through a month without urinary tract infections if I wasn't using Prosterone, which I use every day. When I tried using Vagifem, it made a little bit of difference to my vaginal dryness, but it made no difference to my urinary tract infections. And I've had kidney infections, I've had blood in my urine, I've been really ill with infections over the years, and I just can't tell you how lovely it is to be infection free. And I have been for about 3 or 4 years, touch wood, since I've been using vaginal hormones with my systemic HRT, and I'm very grateful and I feel very privileged to be able to have it, but I also feel very cross that women aren't allowed to have it, and I get messages all the time about them, the GPs not allowing them to have it or not being able to prescribe it. So I hope that's helpful. I've got about 10 minutes or so left. So I'm going to see, there's a few questions on the chat and I've got quite a lot on my Instagram as well. So let me just see if I can access the questions here. I'm a bit slow today, I'm sorry. Let me just see if I can get the studio chat. I can't access it at the minute. Maybe it will come in a sec. Hang on, let me just go to the Instagram and then I'll go back to the studio chat. So hang on, let me just go to the right one. Let me just open the, here we go, because I've had lots of questions today. I'm struggling with urinary retention. Could testosterone help? All our hormones can help, but systemically and vaginally, yes. I've tried using vaginal estrogen gel, but it caused severe sharp pains in my uterus. Now, sometimes people can get some side effects or irritation to the preservatives or the other products that are in the vaginal preparations. So it's often not related to the hormone, it might be related to the additives, if you like. So it might be worth using another preparation. I often find the gel, so Blissol gel, is what we prescribe in the UK, can be really useful as well for people. So I have to pee 3 times at night. Should I increase estrogen to let this stop? Well, it's a combination actually. Sometimes it might be changing the systemic HRT, but thinking about vaginal hormones as well. Does testosterone help with incontinence issues? Yes, it can do as well. So it's not just about changing the dose of estrogen and progesterone. It's actually thinking about testosterone too. I use Vagifem cream. Vagifem and cream, rubbing cream on the urethra, still having symptoms. Well, in that case, I would really consider thinking about Prosterone because it does work quite differently. Still having urinary symptoms, UTI, cystitis with systemic and local hormones. Well, there's 2 reasons. It might be not related to hormones that you're getting those symptoms, or it might be that your hormones aren't optimized. So having the right dose and type of hormones with testosterone, thinking about progesterone, many people aren't given progesterone if they've had a hysterectomy or if they've got marinocoilin, but progesterone is an important hormone for our immune system as well. And then thinking about having vaginal hormones as well. Can you use vaginal estrogen for genitourinary symptoms while still on the birth control? Absolutely, which is what I said before. So yes, you can. Many UTIs before HRT, all great with HRT. Now on Ramipril for high blood pressure and UTIs are back. Help. Well, think about the dose of hormones, but also think about localized hormones as well. Suffering with upper UTI kidneys, painful, been 3 weeks. So again, listen to what I've said before and hopefully that will help. The urge incontinence and stress incontinence absolutely can still improve as well. That's the incontinence, often really important. I know it's a bit boring, but think about your pelvic floor exercises when you're cleaning your teeth or waiting for the kettle to boil. Try and do your pelvic floor exercises because having a strong core is really, really important. It's not just about having the hormones, of course. I use Prosterone at night, but I have a very dry vulva. Should I use estradiol cream too? Yeah, so sometimes when people still have symptoms despite Prosterone, or they have external symptoms, then we'll often prescribe estrogen cream or gel to use externally. The dose is incredibly small, so it's usually absolutely fine to do. Still got some bladder inflammation on HRT. So a lot of people I've seen in my clinic have chronic pain. They have painful bladder syndrome, they have recurrent cystitis, they have interstitial cystitis, they have all sorts of preparations from the urologist, but no one actually thinks about hormones. Often testosterone can make a huge difference. Just in my clinical practice, I see it time and time again, but you have to be really patient. So even when someone's got their hormones optimized, including testosterone, including vaginal Prosterone, if someone's had severe symptoms for many years, it can take 6, 12, sometimes 18 months to be fully better. But once we get there, it makes a huge difference, and the quality of life in some of my patients has just been transformed with the right dose and type of hormones. Needing to wee twice a night, yeah, that's very common, and thinking about hormones. Testosterone is 0.09. Is this normal? No, it's low, and you might benefit from some testosterone. A lot of these questions I'm whizzing through because I've answered already. Can interstitial cystitis can be linked to low progesterone? Yes, it can, and sometimes we'll use progesterone pessary, so we use cyclogest at higher doses as well as estradiol and testosterone, as well as prosterone, to make a real difference for people. How does low progesterone impact pelvic floor and perimenopause? Can it cause tightness? Well, it can just affect the way our muscles work. So progesterone is such a neglected hormone and really important. Still sorely needing and really hoping for content addressing relative androgen excess, please. I mean, some people with PCOS, polycystic ovarian syndrome, they are told they have excess androgen, but it's often they've got low estradiol and low progesterone as well. And the balance of these three hormones is really, really important and often neglected. So I've found the chat now, so I'm going to just whiz through it. My GP has asked to see me re testosterone use. Blood test shows testosterone level 1.6. Apparently the normal is 1.5. Like, do you know what? The levels really change, and I don't know where he or she's got 1.5 from. Our labs, it's 2.3, but we look at the free androgen index, so we look at the SHBG as well and work out the ratio, and normal can be between 3 and 5%. Levels really, really change, and we see that. So levels are only a guide. If you're otherwise feeling well, have no side effects, and testosterone is helping you, then you should be able to continue taking it. I've had bariatric surgery. Should I ask for non-tablet HRT? So body identical HRT is always better, and there's lots of information on my website there about it. I don't get UTIs, I just have to go all the time. So any increased frequency can be related to hormones as well. Can the Mirena coil downregulate estrogen receptors in the bladder and worsen urge incontinence because of that? Well, the Mirena coil can block ovulation. So if it's blocking ovulation, it will block our natural hormones working. So that will then predispose us to all sorts of symptoms, but as well as urinary symptoms as well. Can we get better education for doctors at MCAS? Yes, I'd love to have more education for doctors, but we can only talk to the doctors that want education, and sadly there's a lot that seem quite resistant. My new doctor gave me vaginal estrogen may be helping, but she wants to lower the total estrogen systemically to less than 60. There isn't any reason for that. Maybe you should see someone else. Do vaginal hormones help with interstitial cystitis? Yes, they can, especially prosterone, but I would always consider systemic hormones, especially testosterone as well. I can't get intros here in Holland. Can I get it from the UK? Yes, we do have patients that come over from Holland and then they get a year's supply and then just come once a year. It's such a shame. I'm on all three hormones plus Vagifem and estradiol. Weighing in the night because of low estrogen means no vasopressin. So it's thinking about optimizing your hormones. Vasopressin is something that can be prescribed, but we don't usually because it can affect blood pressure. I just always think if we can have safe hormones first, then that's going to be better. Doctor gave me Vagifem, I think this is saying twice a week, would like to use it more. So Vagifem is a really low dose. It's only 10 micrograms. A few years ago, they had 25 micrograms that could be used twice a week, and then they reduced it. I have no idea why. So some people need it more. So if you think twice a week of 25 micrograms is 50 micrograms a week, and again, that was fine. There were no problems. So using it most days is actually fine as well. Some people do need to use it more frequently, and it really isn't an issue. The dose is really low, and actually very little gets absorbed in the body, and that's why it can usually be safely used for women who've had breast cancer, including estrogen receptor breast cancer as well. It's really, really important that we think about not just our dry vaginas, but about urinary symptoms, because so many women are not being listened to. So many women are having symptoms and not associating it with hormones. And doctors like me 15 years ago are not joining the dots and thinking about urinary symptoms and hormones. So actually for us as patients, we should be trying to educate our doctors. When I was about 38, I went and had a cystoscopy. I had bladder scans. I had a lot of symptoms. My husband's a urologist and he didn't pick up on the fact that it could be related to my hormones, and I'm sure I had low testosterone then. I didn't know women had testosterone. I didn't ask for a blood test. I didn't ask for a trial of hormones, and I should have done. And so I think as patients we need to be quite advocating for ourselves. There's lots of information, there's lots of research about how urinary symptoms can reduce and improve. You know, Rachel Rubin's research looking at urinary tract infections and Prosterone. Prosterone is superior to vaginal estrogen, so we really should be helping each other, and we should be helping our doctors by maybe educating them as well, because it's so rewarding as a doctor when I see women and they tell me that they haven't got any urinary tract symptoms, that they haven't had a urinary tract infection for many years. Like, it's amazing because I know how awful they can be for so many women. So I hope that's been helpful. For those of you that are live, I'm sorry that I was late. There was a problem with logging into my Riverside, which is the platform I use to get it out to YouTube. But thanks for all your support and encouragement. And let me know through my Instagram of other topics that would be useful for you, because this time is for you to try and get as much knowledge and information as you can, which will help hopefully your future journey and also help you to educate other people too. So enjoy the rest of the evening if you're in UK, or the rest of the day. So thanks so much. Bye.